Sure. All right. Good morning, everyone. Thank you for joining today. I'm Stacy Valender. I'm a family physician and medical director of the Evaluation Sciences Unit, which partners with Stanford Medicine Center for Improvement, SMCI, which is the host of these awesome talks. We very much appreciate everyone's attendance here today. And we're very excited to welcome Dr. Cesar Padilla and Chris Lemelle to talk about the Green Button Project at Stanford, utilizing digital health tools to impact care delivery and health equity. Before we get started on their introductions, I want to just mention we are approved for all of these talks to give CME credit. And so Selena is going to put that message or that information into the chat. We typically talk, we hear from our guests for about 35 minutes and leave about 10 minutes for questions, 10 to 15 minutes for questions. So we try to end 10 before the top of the hour. As you think of questions, feel free to drop them in the chat, and then we'll circle back to those towards the end. We have had a really fun time planning these SMCI talks. We have two upcoming ones that are confirmed. I just want to mention September 13th, Dale Lupu, Woody Moss, and Glenda Harbert are coming to us from George Washington University School of Nursing to talk about the culture of care for patients with kidney failure. And then we've just confirmed our own Neeraj Sehgal, our Chief Medical Officer over on the adult hospital side, to talk about improvement in our home institution. So we'll be sending information out about that in due course. On to introductions. We are excited to welcome, Dr. Cesar Padilla. He is one of our own clinicians. He's double fellowship trained in obstetric anesthesiology and critical care medicine, coming to us from the Brigham and Women's in Boston, and more recently the Cleveland Clinic, where he introduced the obstetric comorbidity index, which will be a focus of this talk today. He's authored two books on management of critically ill obstetric patients, which are some of the scariest patients. I know having done family medicine training, we need to take good care of those patients, certainly high risk. His current research interests include the validation of risk prediction tools like the obstetric comorbidity index, which led him to his work with Atropos Health and the focus of today's talk. Dr. Chris Lemelle, MD, MBA, is fellowship trained in pediatric anesthesiology, has private practice, and he's currently the Senior Vice President of Clinical Strategy and Implementation at Atropos Health. They may introduce this, but just a quick overview. Atropos Health is a private company that's spun out of Stanford's Dr. Nigam Shah's lab. And it is a product that is an informatics console which can answer clinically complex questions to provide statistically validated real-world evidence to guide clinical decision-making. So we are very excited to welcome them today. And without further ado, I'll turn it over to, I believe Chris is starting.
Thanks, Stacy, and thanks everyone for having us. I think in the interest of time, I will give you a brief history of the Green Button service and also share you a brief example. I won't go into depth as we usually do on different department meetings here, just because I think it's more interesting to see the work that's come out of the service, which Cesar will cover with his two subsequent topics. So moving ahead, really, we're trying to address an evidence gap that exists in medicine. We know that most, at least widely accepted care decisions, protocols, good research, the gold standard is basically randomized clinical trials. But we do know that because of how those trials are structured, they do remove a lot of confounders, and confounders usually means other comorbidities. So oftentimes, when you're dealing with complex patients, there may be a gap in what evidence is there compared to what's being published. And it's really that gap that we're trying to address with Atropos. We provide real world evidence, and we try to fill that gap, and especially in populations where they aren't really well studied. Just as Stacy mentioned, it won't really go through this entire timeline, but this shows you the research that went into the service, more commonly known as the Green Button service within the Stanford community. Spun out in about 2019 because the CEO's office thought it was such a great service that we really should go and give this to the walls beyond Stanford. And so we've been live for about a year at Stanford. I can just jump past that, but really, what is the platform? It really is a service, and we designed that intentionally. So overall, we intake questions from clinicians, researchers, or even non-clinical people. And when I say we, it's an informatics trained physician. They structure your question into a research question, which then is where the technology takes over. That technology does really two things really well, really quickly. And when I say quickly, we do what Research IT has quoted us would take them 3 to sometimes 9 months. We can do that in usually 24 to 48 hours. But the technology does two things. It looks at the data from the Stanford EMR that's been filtered out. It creates cohorts really quickly to compare patients. And looking at those patients, we then do a statistical analysis to understand for the intervention or diagnostic or therapeutic that you've tried to understand how will it impact this patient or patients. Here's what we see in the data to offer you an additional data point. And you see on the far left, it's been used in multiple different ways at Stanford. Probably most utilized here are research and then care protocol questions. Building on that experience, really, we're able to then aggregate those reports into a library at Stanford. And what that does is it lets you look at really at the Stanford community what is happening in real time based on the questions asked. Oftentimes what we found is this generates other questions. People will see a particular report. They'll say, aha, I've been wondering about this particular question, but I may change certain parameters and get a different outcome. So it's a very valuable asset. And just a note about data, the data that we sit upon really at Stanford is from the Stanford electronic healthcare record. What we are not is a way to track down individual patients. Just because of the way that data is handed over to us from Stanford, it goes through a couple of filters. So we'll never have an exact one-to-one match of all patients at Stanford. But for the most part, we have about 97% penetration into the EMR data. We also sit on data sets outside of Stanford. Those range in quality from very specific curated data sets like ASCO CancerLink to very large national data sets like Truven that we have. So this is a summary, a workflow of how the servers work. Again, it's designed as a consult. We have an intake question. You can submit that question just quite literally as a question. Our informaticist may contact you to make sure the question is structured in the P-code format. The process that I described in the earlier slide happens where we have our technology plus our data science team plus our clinical team basically look at your question, run it through our technology, and finally give you a report. Our methods, just so that you know, on the far basically left are what we have been evaluated against. So we are in peer-reviewed journals, and the outcomes of our reports have been used in multiple research publications. At Stanford, we're currently at about, I think, 15 or so papers in various stages of publication right now in less than a year. So we're very proud of that. Here's where, before I hand it off to Caesar, I will just show you really quickly so he can really get into his piece of the presentation. An example, so you understand the report that you're getting, this is what's driving some of the insights that Caesar will share. So I'll quickly show you that in a moment. Just give me 1 second, Caesar. I may just show a prognostogram.
For sure.
Thanks. No worries. This was an example of a report that was submitted during the height. By the way, we call our reports progностograms. We aren't marketing experts. We're data scientists and clinicians, but it's in the form of a report. I won't go through in detail the report, but basically you get to ask a question. This particular clinician wanted to know were there increased use of chemical restraints during COVID visitor restrictions. The question was simple, just submitted simply as that. And really they found that there were indeed more judicious use of chemical restraints during restrictive visitor policies. Substitute the family members redirecting patients with a chemical sedative. And that led to some questions about how sedatives were used. And it led to some protocol reviews in certain departments. Won't go into depth of it. I will share the report after, but just wanted you to see that this is really the clean summary and it has all our methodologies and statistics following to show you this is how we generate those outcomes. Caesar, take it away.
Thank you, Chris. And I just want to thank everyone for the invitation to share this important work. So let's see. Right. Current slide. Okay. So as a double fellowship trained physician, both in OB anesthesia and critical care, it's sort of this unique combination of two worlds where I remember when I was doing these, this training, people are like, well, what does one have to do with the other? And, it turns out that there's a lot of sort of overlap in this, in high risk obstetrics. And really what I hope to show you and inspire you all, recent evidence based tools that can actually predict which patients are going to get sick or who are a high risk. So I'm going to start off by talking about the obstetrical morbidity index. This is a really crucial sort of piece that I'm going to be discussing, which sort of is going to be the foundation for my talk. Unfortunately, in the United States, we stand out as the amongst high income countries, we stand out as the country with the highest mortality. And so in pregnancy, and to put that into context, compared to women in France and Canada, women in the United States are twice as likely to die. And unfortunately, these numbers are even greater mortality numbers amongst ethnic and racial minority groups. Black women are most likely to die in the United States, Native American women, and with the onset of the COVID pandemic, the mortality in Hispanic, Latina women almost doubled. Since the onset of the COVID pandemic. And, unfortunately, this also depends in, the zip codes where you live at as well. So when we're looking at end organ dysfunction, such as ARDS, sepsis, intubation, these are clear markers of something, high risk pregnancy, something usually goes wrong in the sense that, a patient has some kind of organ dysfunction that probably these patients are probably in the ICU or are just really sick where they need that extra attention. This is the prevalence compared in a predominantly Black zip code, which is Baltimore, and a predominantly Hispanic zip code with Salinas, which is about 2.5 hours away from here. We're looking at the prevalence of organ dysfunction for these diseases compared to majority white zip codes. You can see a dramatic difference. And so when we sort of break down not only who gets sick, but who is dying, why are patients dying in pregnancy, it's really also important to, and if you look at the red bar, to note that cardiovascular conditions have increased dramatically. And so what we're looking at here is data from the CDC, which breaks down by color code. So the code here, or the dark blue, is going to be from the 80s, and basically it's just moving from a condition from the 80s, and then it's taken by 3-year bars up to more recent times. So you see an aggressive increase in cardiovascular conditions and cardiomyopathies, which is basically to say that our patients are getting increasingly sick. So really, we have multiple problems: an increase in mortality, patients are dying from more medically complex conditions. The leading cause of death in the United States in pregnancy is cardiovascular conditions, which we also see in other high-income countries like Australia and the United Kingdom. The top cause of mortality in pregnancy is cardiovascular conditions. And then unfortunately, ethnic and racial disparities exist. And really putting this problem together of having this very clear problem of mortality and the burden of mortality in high-risk women and racial ethnic minority groups, it's really crucial to sort of take a step back and look at the forest from the trees and see, well, when is it during the course of pregnancy and delivery that patients are dying, or when is most of the morbidity happening? And it's actually on the day of delivery and after delivery. And so one of the questions that has come up in the literature, if you will, call this a paradigm shift in the field of high-risk obstetrics, is, can we use the antenatal period from the time a woman becomes pregnant? Can you use those 9 months as a head start to get things ready, send the patient to the right physicians to get worked up, to get more information? Can we use the antenatal period to identify who is going to get sick, who is going to develop organ dysfunction, who is going to develop ARDS and, the sort of some of the conditions that I mentioned. So really using this period. Now, this is a topic that has taken off internationally as well. So I was invited to Mexico City to give a keynote at the annual Anesthesia Society meeting precisely on this topic. So I think it's important to highlight that SEMI, this group, is touching upon something. You guys have your finger on the pulse for a conversation that has taken off globally as well. For example, in the UK, people actually say, like, obstetric critical care, this problem and this field is actually a new field in medicine. And so this is something very, very new in the literature, which I think is important to point out. So what is the obstetric comorbidity index? Now that I've showed you the problem, I think it's critical to show you, the solution as well, or in our perspective, a potential solution. The obstetric comorbidity index is a validated tool. It's a validated index that was developed at Harvard by Dr. Bateman. So Dr. Brian Bateman, who was previously at Harvard, is now currently our chair of anesthesia here at Stanford, and actually met him at Brigham when I was there in Boston. So call it the fate of the universe. And I was, privileged enough to be introduced to this tool that he invented. And basically what it is you have this series of medical conditions. And these medical conditions have a number next to them. And that number basically is an odds ratio of who's going to develop organ dysfunction or severe maternal morbidity. You can use severe maternal morbidity as a surrogate for like ICU level care. It just means who is going to develop organ dysfunction where they're going to require the extra sort of level of care. So if you look at the top, it may be a little small, but there's 5 points assigned for preeclampsia with severe features. So these patients are 5 times more likely compared to a patient who does not have this to develop end organ dysfunction. Now, I think it's very, very critical to state that this is the only validated index in pregnancy that can identify high-risk patients, in the sense that it's the only tool that has been validated prospectively. It's been validated in databases for like in other population groups in other countries, and it's also been validated prospectively. So they've actually followed patients in real time and said, yeah, this works. There are other indexes, but they have not been validated prospectively. So in terms of indexes that can predict who is going to get sick in pregnancy, this is definitely this sets the bar. This is the only one that has been validated prospectively. So I work on L&D. I was just there on nights, Sunday night, and this is a very common scenario. So right now, the way that we treat patients is, okay, let's say you have a 36-year-old patient, first baby, and the patient has signs of sepsis or an infection. This is patient number 1. And so if we were to apply this tool, so currently this is not introduced in EPIC, and we don't use this tool now, but I want to show you the power of how we can utilize this. So this is a patient with no medical conditions. She just gets a point of 1 for her age. This is patient 1. We take the exact same medical scenario, which is a patient with sepsis or an infection, and now this patient has asthma, has chronic hypertension, substance abuse disorder, it has a BMI of 45. This patient has a score of 8. What does this mean? And by the way, a lot of these medical conditions, you can actually you can calculate these at any time during pregnancy, probably except for preeclampsia with severe features, because that is a hypertensive disorder of pregnancy. But patients who have pulmonary hypertension, this is listed there. Patients usually know, if they are followed by physicians, that they have that on the onset of pregnancy. If they're diabetic on insulin, if they have a history of epilepsy. So this is a tool that can be used early. And so remember, the original question, can we use the antenatal period to predict who's going to get sick? So we have patient 1 and 2 who present with an infection. On the y-axis, what we have here is ICU level care. So this is going to be severe maternal morbidity or organ dysfunction. And we see a dramatic difference in the percentage of who is going to develop ICU level care or severe maternal morbidity. Now, this data here that I'm presenting is taken from that prospective study that was done at Harvard that followed these patients in real time. This is the paradigm shift. It is absolutely fundamental to really just sort of focus on this here, because at this time, the standard way of really approaching high-risk patients is not really to take a step back and quantify those comorbidities. It's just like, okay, so we have 2 patients with sepsis, and there's really no difference in, in the sort of risk assessment right now. Now, of course, if you have a patient with a lot of medical conditions, sometimes we can, in our mind, but we all know we're overwhelmed with, messages in terms of, EMR, this and that. And so it's really key to have sort of, call it a calculator, high risk calculator that can sort of aid you in identifying which patients are sick. I worked with Atropos and really want to thank the team because we applied the OCI score. So I'm calling the obstetric comorbidity index OCI to our patient population at Stanford. And lo and behold, yes, there is a difference in the OCI score of patients who end up in the ICU. So these patients who end up in the ICU during pregnancy have a higher comorbidity index score. And so this is basically showing us that, at least sort of highlighting that this is potentially also, validated here for a patient population at Stanford. So what is the role of the OCI in identifying high-risk patients? In my first job at a fellowship, we introduced the OCI into Cleveland Clinic, which is a massive hospital, into their EMR. That was the second hospital in the country to have it behind Harvard. The entire Harvard hospital system has it. I think now Duke has it. There's a few other. But this is really the opportunity because what we're talking about is a validated tool. It's predictive of who's going to get sick. And this intersectionality of that and technology is key. Because, and I'll give you an example. At Cleveland Clinic, whenever a patient shows up to L&D, the nurses fill out the obstetric comorbidity index, which is very similar to what happens at Harvard. And so this is key because it takes a few minutes to fill it out, but it's on when women arrive for delivery. So we're leaving out the opportunity even before that in the EMR, for example, in the first trimester of pregnancy. So really talking about these prediction tools and their potential in identifying high-risk patients, because the other part that is very critical is that we have to make sure we're capturing these patients from the community and they're sent to appropriate level hospitals. And what that means is if you have a high-risk patient that potentially goes unnoticed and they go to a hospital where it's not appropriately staffed, or a lower tier hospital, which are the American College of Obstetrician and Gynecologists, they label hospitals based on their sort of level of complex care, kind of like NICU or trauma classifications. The risk of organ dysfunction increases by 50%. So if you send a high-risk patient to a level hospital that is not appropriately staffed, there's a 50% increase in the chance of organ dysfunction, which adds about $1 billion in added expenditure in the US for healthcare. And the other part that's critical and that really hasn't been investigated is, well, can this be used to reduce racial ethnic disparities? Because, can a tool like this be potentially, something that can be used to check the bias to check human bias? And that's very interesting because it sort of really ties into the health equity aspect of our talk here. So in the last 2 years, this is what I mean by paradigm shift is there have been very sort of high impactful papers that have come out from one of them from MGH in Boston and another one from Kaiser, where they arrived to the same conclusion. And this is powerful in medicine. It's like two different, vastly different from different states, they arrived to the same conclusion, like, let's pay attention. And what they concluded is that you can use the antenatal codes, meaning you can use the comorbidities of patients as soon as they get pregnant, quantify them, and lo and behold, if they have more comorbidities, just like the obstetric comorbidity index shows, you can predict who's going to get sick. And that's the paradigm shift, is like, are we missing out on this opportunity to use the antenatal period, to use ICD-10 codes, to use validated tools like the OCI to predict who's going to get sick? The paper from Harvard, basically in their discussion, they said the following. So again, they just used their computer models to use those ICD-10 codes beforehand, and they were able to create these risk prediction tools. Quote, importantly, these types of models can be employed to reduce the risk of implicit or unconscious bias in providers' subjective assessment of risk. This may help reduce disparities in severe maternal morbidity by race. The reason why they said this is because they found in their cohort of patients in Boston that they found disparities in they found that Black women were overrepresented in the patients who had higher higher likelihood of ending up in ICU or having severe maternal morbidity, and were also lower income. So they found these associations with that as well. So that's why they came to that conclusion. So if we can predict who's going to get sick, and this tool is helping us identify potential disparities, can it be used as a tool to reduce those disparities? And then, of course, to refer patients to a higher level of care for early medical optimization. This is absolutely fundamental and fits in what national societies are saying about identifying high-risk patients. And I had the chance to sort of put this message together of this being new and presenting this to Harvard Business Review. So the authors there are other Stanford anesthesiologists, obstetric anesthesiologists, Dr. Abir, Dr. Carvalho, who is our director of OB anesthesia, and Dr. Sikowski is the past president of the California Society of Anesthesia. So these are some of the leaders in anesthesia. But what's really key is that even the business community is paying attention to this, because what we're talking about is this very, very, very new intersectionality and potential of data and healthcare. And I think that's important because I can't tell you how much attention we received from this Harvard Business Review article, but I think it says a lot because people are paying attention, certainly at the C-suite level. And that's how I saw it. I saw it, a lot of executives reached out to me, which led me to believe that, yeah, a lot of healthcare executives really care about this message a lot. Now, I'm going to change gears a bit, but sort of still using that mindset of data and validated tools. It's not just, in pregnancy, or that I'm really focused on looking at these disparities, but also pregnancy within medical education. And so you can imagine, right, if we can dramatically change the experience of a medical student, if we introduce them to the OCI early, or if we introduce them to concepts of healthcare disparities in our own patient populations and pregnancy. And so keeping in, just using the framework of using digital health tools to reduce disparities, I think a very important question is, if you're a medical student and you're rotating on your OB rotation here, well, you should know, or you should have a snapshot into the disparities of our own patient population here. What should we expect? Because that's going to really sort of not only prepare the medical student, but perhaps even prime them for helping them come up with some of the answers that we need. So one of the examples here is, this is research that was conducted this summer by one of our incoming medical students as part of this, it's a research summer program called the Leadership in Health Disparities Program. And we were able to ask the question, are there racial and ethnic trends of fetal deaths during the COVID pandemic? And what is this data pre and current pandemic? And so we define, and this is again an example of how we can really impact not only care, but education, which is really sort of the hallmark and mission at Stanford. So we define intrauterine fetal deaths, very unfortunate outcome, as or stillbirth, as occurring when the child dies in the womb after 20 weeks of gestation. But really the question, which hasn't been answered here at Stanford, is what's the racial and ethnic distribution of IUFD stillbirths in the pregnant population? And what we found was pre-pandemic, there was disparity. So Black women were overrepresented for fetal deaths, followed by Hispanic women, and then Asian women for fetal deaths before the pandemic. And unfortunately, this increased both in Black women and Hispanic women. And this follows national trends as well, where we know there was an increase in stillbirths and fetal demises during the COVID pandemic. Now, when the students presented this, I can't tell you how inspired they were to not only understand this data, but the respect behind their eyes, behind knowing that this is happening in our own community. And how powerful is that, to really understand that when they rotate on OB, they have this deeper understanding of what our disparities are here. So Dean Lloyd Minor uses a term, precision medicine. I'm going to call this precision education. This is really what we're talking about. We're talking about precision education, whether you're talking about the obstetric comorbidity index, or you're talking about, tools where, using digital health tools through Atropos to understand who your racial and ethnic trends. This is really a snapshot into, or has a potential really to drive this narrative of digital, digital precision or precision education. Now, there was a few, I would say not setbacks, but just a few minor points to really discuss regarding our patient or this data, which is that our data was only from Stanford University or our patient population here for the fetal demise data. There was some incomplete data as well. For example, we're missing financial information. We know that women of low socioeconomic status are more vulnerable, more likely to experience adverse outcomes. And then we don't have access to, or Atropos did not have access to COVID vaccination status as well, and or able to break down the difference between vaginal and cesarean sections, which is important to note because C-sections are associated with higher risk. And so just a few minor points to point out. But okay, that's the end of my talk. But I just really want to close by saying that we really have an opportunity here. I cannot really stress the fact that we're so lucky to have Dr. Bateman here, and to have the potential opportunity to really help introduce these evidence-based digital health tools that are not only good for our patient population, but just good for society as well, on a large scale, because we could really help drive the narrative to help reduce disparities on a national level. And I think this is where Stanford can really help lead and help inspire other institutions to do the same. So I think with that, I think our goal was to finish roughly 25 minutes ahead. So we want to leave the rest of the time for discussions, and I'm happy to take any questions.
This is just so awesome. Thank you so much, Cesar and Chris, for being here and talking about this important topic. As someone who ended up being a high-risk OB patient myself, it gives me the chills to know that these changes are taking place, and we're really taking advantage of all the data we have at our fingertips at Stanford. I have just a couple questions right off the bat. I'm really interested in maybe, Cesar, if you could talk about kind of traditional forms of developing these risk tools. So it was the OCI, it sounds like, was developed at Harvard, was implemented there. You brought it to Cleveland. Now you've been part of bringing it to Stanford. So presumably those are based on more traditional methods, but then we've used the Green Button Project to validate it at Stanford and look at it amongst our own data. And I'm guessing that latter process was faster. So this sort of like validating the tool in a home institution, Green Button helping to do that faster versus kind of like the more traditional, like longer, like the way that you originally came up with OCI itself. Can you talk about the benefits of those two different approaches?
Sure. So, I could talk. So I think one of your questions is like, how was the OCI even developed to begin with? Is that kind of?
Yeah, maybe starting there.
So I'll start there. So it's very clever. So, I have to say, like, Dr. Bateman kind of reminds me of like a Silicon Valley kind of Google kind of, just really good insight, because no one this is the mid 2000s, late 2000s, like 2010, 11, actually the beginning of the decade. No one had really looked at, okay, out of women who end up in the ICU, what if we just look backwards and just see like, well, what are those comorbidities in those patients? So what they did is they took data from they looked at data from the Medicare, Medicaid, national, so Medicaid data set. So it was, believe, close to 1 million patients that they looked at. And so this is really one of the strengths that Dr. Bateman brings, is big data sort of analysis. So it was about 1 million total patients that they looked at. And then they sort of, looked at the data, of course, retrospectively, and sort of broke down by their endpoints were who ended up and it wasn't just who ended up in ICU, but who developed severe maternal morbidity or end organ dysfunction. And that's how they saw an overrepresentation of preeclampsia with severe features, hypertension, congenital heart disease, cardiovascular disease, which is fascinating because if you look at the top 5 conditions in the OCI, it's cardiac it's all cardiac. And then when you take a step back and see, well, who's dying? It's cardiac. And this is, again, like I mentioned earlier, it's not just in the US, but in other high income countries like the UK and like Australia as well. So it's very fascinating. It's almost like they got to the answer working backwards.
Mm-hmm.
And they were able to validate that and show that. And then what they did then is they took that same scoring system and then they applied it prospectively, and they were able to, in fact, validate it. And I think they validated in Denmark, in Israel, and there's a Netherlands, I think is the other country. And so, of course, that's a long process, right? You're talking about like even creating something first. You have to look at, you have to start with a step like that. But the fact that it's already been, examined and studied for over 10 years now, I think is powerful. And then your second part of the question, if you don't mind repeating, or maybe if it might change now.
Yeah, well, I just thinking of that process. So slow creation of the OCI and then bringing it to Stanford and validating it in our population. Is that step necessary? Like, so you're using the Green Button project, I presume, to do that. It sounded like, and you mentioned the term precision education. So kind of using these themes and using the Green Button project. I'm just curious for you to speak more on that.
Yeah. So in terms of it being validated here, and Chris, if you want to speak more to this, we did run a query to Atropos through Atropos Health, and we saw that yes, like in fact, the numbers do match here, and high risk patients do with the high OCI do end up in ICU. But this is a scoring. The OCI is not built into Epic. It's not. It's something that we have as part of our care currently, and so it's we're looking for allies to help with that. So it hasn't been, so I don't know in terms of specifically from the Green Project, I don't think it has gotten there yet. Chris, is that correct?
Yeah, Stacy, to your point, I think we're in the look. Oftentimes, large complex healthcare systems want to see, does a particular scoring system work within their population? So we validated that for Caesar pretty quickly. Again, compared to how it could be done or would have been done versus how we did it, I think it took like a month or so because it took a little bit of a complex model building exercise. And then what it's enabled them to do is sort of test weightings of those different attributes that you saw in the scoring index. So is there a way to refine the tool? So that's sort of forward-looking research. I think the next step that we're all hinting to, it's really a bifurcation. So now that we've proven this at Stanford and it's based on years of research, how can we implement it? I think that's something for this group to perhaps weigh in on, since I don't want it to be just a lecture, but a participation. That's one part. The other part is using it beyond just obstetrics, but to sort of define, how can we use a tool like this for Stanford to be a learning health center focused on health equity? My 2-minute, experience in that sort of exercise is that a lot of times healthcare systems make big bets or assumptions that, hey, we think in A population that B is a problem, therefore C, the intervention is this. Unfortunately, that's usually based on anecdotes versus data. So we've used the Green Button service, as Caesar showed, across multiple other different questions to say, okay, is this a problem? If so, what should we do about it? So we can validate the problem, and then we can then sort of measure intervention impact. So let's say, for instance, using a well-known example, Kaiser is placing a $10 million bet or so, maybe more than that, on providing housing for people. So is that going to have an impact in the health of that community? Usually that's the post-intervention measurement that's not really looked at. Again, you now have this tool at your fingertips at Stanford to say, fine, we made an intervention. Let's look at what's happening over time to say, was it impactful? And if not, what do we need to do?
Yeah, that's really important. You're speaking to both the kind of the retrospective, we have a hypothesis, let's look at the data we have, and then as well as looking at setting up prospective evaluations. Essentially, we're the evaluation unit partners with SMCI. So how can you use that data to kind of just track, you use the Green Button to track that data over time to evaluate these interventions. And I just want to invite anybody to put questions in the chat, and I, if you want to type them in the chat, and then I might call on you to elaborate if it's needed. You both have spoken to this kind of challenge of, once you have the tool, how do you actually integrate it into the workflow? And so, and Chris, you're very generous to try to open up the floor and kind of, let's throw ideas around here. Something the evaluation science unit has worked on is something called normalization process theory. So just this idea of, once you introduce something new, how do you get it into people's everyday kind of the patterns into which they practice? Our own Ron Lee and Margaret Smith had given a talk on integrating AI generated mortality prediction scores into trying to get more palliative care consults ordered within the hospital, instead of it just kind of being like a clinician's gut feeling. How can we actually get them to base that on data, and can we improve equity in that way? So maybe Cesar, what challenges have you faced getting, implementing the OCI into practice? What did you see at Cleveland? How did you overcome those challenges? What are you seeing at Stanford? I'm curious.
Yeah. Oh no, I love that question. I was like eager to answer that because yeah, because I saw it in real time. So here's how it went. So when I left Brigham, I heard that they were implementing the OCI there at the Harvard system. And what Dr. Bateman did, which I thought was really key, is that he introduces as a nurse-driven tool. So the nurses calculate this on Epic when the patient arrives to labor and delivery. And so in the way I understood that was making nurses a critical part of the team, and not just something that the physicians calculate. And then if there's a high-risk patients, they are alerted, like the team is alerted during safety rounds. So like there's usually like these safety rounds on L&D like twice a day, where you highlight, patients, and then you go over really sick patients. So I didn't want to reinvent the wheel, and I was like, yeah, that sounds like a good idea. I'm going to do that. So when I was at Cleveland, I introduced this as a nurse-driven tool. Now, what's interesting is when I presented this idea, it immediately went to the Chief Quality Officer of Cleveland Clinic. And so I think it's really key to state that we have sponsorship at the highest level of the hospital, because you need that. I mean, if you're going to introduce something across an entire enterprise, you really need that sponsorship at that level to say, okay, this is a good idea, we're going to do this. And so it was done as a nurse-driven initiative with sponsorship from the CQO of Cleveland Clinic. Now, here's what's cool. And I think this is, and I would love for nurses to, if there's any nurses or anyone who's worked on L&D to chime in here, is that we found that the nurses were actually empowered to do this, because all of a sudden they were like, whoa, my patient has an OCI at 10. No wonder I'm tired on L&D at the end of my day, because this patient has preeclampsia, hypertension, this and that. And this is like exhausting. And right now there's really no way to differentiate who has a high risk patient, or, in a sense, from just looking at an objective, one number. And so this was nice. And so there was already conversations at Cleveland Clinic about like, well, should this affect the nursing to patient ratio if they have a high OCI score, right? It's like very fascinating. So I think in a lot of ways, it sort of validated the nursing experience, which I thought was nice, because it's so easy for a patient to arrive, and those medical conditions are sort of hidden in there, and no one really quantifies them until you take a step back, you use a calculator, and you're like, whoa, this patient has a score like 12, and this is a really high risk patient. And so that's the benefit of having, not only a scoring system like this, but applying a number. And it's not all about the number, right? I mean, there's patient care that comes in, but just to have that extra sort of validation, I felt we saw immediate buy-in from the nurses, because not only were they part of the team, but they were actually like, yes, I am taking care of this high-risk patient, and I am letting the physician know. So the way, I guess, if you would ask, how would that affect downstream care? Well, it immediately alerts the anesthesia team. And me, I need to know who's high risk, because I do a lot of, for example, point of care ultrasound. Just the other night, we did a point of care ultrasound, and we're looking at heart function, this and that. And I need time, because there could be 2 C-sections running, just like there was the other night at 3 a.m. And to plan and to know who has a high OCI score is so indescribably important. I can't even say that. So anyways, so I know I packed a lot in there, but yeah, if there was like, anyone that wants to jump into the conversation, I'd love to hear, thoughts.
Yeah, and that point of, kind of like the inductions that might wait a day because of the collective OCI score and the ward is just too high, right? Like you're pushing back those elective C-sections, is something changing up maybe the nursing to patient ratios, or at least, if each nurse has 2 patients, let's try to balance the scores so that the workload is a little bit even, I think are all very actionable things that are informed by that score. We have a question. Does the RN have to manually check the boxes? Are you able to pull diagnosis codes? So this is, and feel free to unmute yourself and elaborate, but it looks like this is this question of wanting just to know what level of work it is for the nurses.
It's like, I can't tell you exactly, like when the patients would arrive for labor, there's like a standard, I don't know, like just workflow that the nurses would do. And this was like another step in it. And it was about 2 to 3 minutes that it would take them to calculate it. So all it is, if you look at the index, you're just basically going through pretty much simple questions. Actually, if I could share my screen and I could just show the index, I think would be very powerful. Is that okay?
Yeah.
Here we go. Yeah, here we go. So yeah, just out, how long would it take us to run through this? Okay, does the patient have congestive heart failure, pulmonary hypertension, intrauterine fetal demise? This is here, multiple gestations, asthma, diabetes, insulin, age, and BMI, alcohol abuse. I mean, this is like, it takes 2-3 minutes. It really, now, there's some nuances. For example, if someone has, let's say, ischemic or cardiac arrhythmia, is this something is this arrhythmia something that the patient was just told, yeah, maybe I have every once in a while I have a bit of arrhythmia, or is this something more serious, like the sense that, yeah, I am on metoprolol every day because I have this uncontrollable SVT, right? So it's not perfect, but it very well does like sort of put everything into one nice concise number. So in other words, it doesn't take that long. And now this is the paper format. This was in Epic. So it was like literally clicks, like click, 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 and then the computer adds it up for you here. And then it even has like sort of a nice sort of algorithm here of what to do. So circle the comorbidities, notify the responding clinician, kind of what we talked about. So this is really like sort of a nursing handoff template. And that's how we started at Cleveland Clinic. We started this with paper, and then because we needed just to introduce the idea to the nurses, and then it went into Epic. It took about 2 months for them to put into Epic with their coding team and all that.
That's great. We are at 9 minutes to the top of the hour. So I wanted to just ask one more question. We'll have one for each of you actually, but the last question for Chris, and then we'll let people go if they need to go, and then we can keep chatting if others have burning questions. So Chris, what are the steps if clinicians want to start to use this product for their own hypotheses? And
absolutely. So basically very easy, 3 pathways. In the material that I'll send you, we'll lay those out so you don't even have to remember, but you can either go to an intra website, click a link, and just fill out a standard intake form, or you can send an email, just free text, or there's a QR code that will lead you to another portal. So we try to make it as seamless as possible and easy. And that kicks off the process that I talked through pretty quickly, but will be in the slide deck. One caveat, one thing to mention, because I didn't, always, what's the cost? So Stanford approached this as free to the community. It's being funded by the CEO's Innovation Fund, so no cost to any department, provider, or patient to ask questions away. Again, in the distribution of materials, you have all the ways to get to the service, and I encourage you to use it. If you have burning questions that have been sort of, I have a concept or a hypothesis that I want to validate, at least directionally even, we're very good at that.
Yeah, and that example you gave before about chemical restraints and the visitor policy is, I think, what was fascinating. Anybody, non-clinicians, can can use that service. So I think we will say goodbye if you have to go. Cesar, I have one question for you that I'm very curious my own self. So the nurse driven, so filling it out, it sounds like they're filling it out once they get on service, but do you have a process where they're doing it kind of like month 2 of pregnancy or month, where you talked about let's move it for earlier in the antenatal process? I'm curious how you're addressing those challenges.
There was talks about that at Cleveland Clinic, and then of course the pandemic happened.
Oh yeah.
So that really put a lot of pause on things. And then I came here, and I've been here for a year and a half. But yeah, there was conversations moving in that direction. I think that's the exciting part about this tool is that we can use those preceding 9 months to optimize a patient. And that is so critical because, for example, we see our sickest patients in our pre-anesthesia high risk clinic, and they're usually referred to us from our obstetrician colleagues or MFM colleagues. But could we potentially capture previously uncaptured patients who would have sort of flown under the radar if we did not apply this tool? And I think the answer is yes, there's no question. But yeah, we were moving in that direction. And I think that's the exciting part about this tool is that it can be used in the antenatal setting.
Yeah, this is amazing. Just so much potential here.
Mm-hmm.
My net's a little bad. Hopefully you guys can hear me. And I just want to say thank you all so much for coming. And a huge thank you to our special guests today.
Thank you guys for having us.
Yeah, thank you very much.
This is just awesome. Take care.
Bye.
Bye, everyone.